Welcome to the Speaking of Women's Health podcast. I'm Dr. Holly Thacker, your host and author. And today, in March of 2023, we're going to be talking about customizing hormone therapy. Now, please remember that this is not direct medical advice. It's just helpful information to empower you to be strong, be healthy, and be in charge. And throughout the podcasting and updating of this book, we go over lots of resources where you can find a women's health expert and what things you need to be looking for and how you need to arm yourself with resources so that you can make the best decisions for you. So, hormone therapy is not a one-size-fits-all solution. Hot flashes might be one woman's most severe menopausal symptom, but her sister or friend may be more concerned about sexual dysfunction. Her best friend may worry about rapid bone loss because her mother broke her hip. Our experiences during midlife varies, and menopause symptoms may or may not require hormone therapy. But if they do, there's many different formulations and a wide variety of types. One of the most universal concerns that many women have is based on weight gain, which is not a classic menopausal symptom per se, but with age, metabolism slows down and most all women gain weight. And we covered nutrition and weight gain in an earlier chapter that you can listen to, and we're going to have future podcasts on that. Another big concern women have is skin and hair, which we've also covered as well, and we'll cover in a lot more detail in upcoming podcast. Because the women I see in my practice usually have reached their last straw by the time they see me, they may be uncomfortable, unhappy, and sometimes even desperate. So hormone therapy is usually an option that I put on the table right away. Many of my patients may already be taking some sort of hormone therapy or filled a prescription for it in the past. But many times they aren't always taking the right amount or the most appropriate type. So many times we need to individualize the dose or change the delivery system for better results. Take Miranda, for example. Miranda has a very healthy lifestyle. She exercises daily. She follows an organic vegetarian diet. She's always been sensitive and had many allergies, and standard doses of most medicines are usually just too much for her. When she entered into menopause, Miranda was very concerned about taking anything foreign or synthetic. And she didn't want just a standard one-size-fits-all treatment. She knew she needed something because the hot flashes, vaginal dryness, sleep disturbance, skin and hair changes. She felt the skin under her eyes were so much thinner and more delicate. So this made it impossible for her not to seek out some sort of therapy. Miranda wanted a regimen that would fit in with her lifestyle, and she wanted a physician who would support her in using the lowest doses of natural hormone therapy. She had been to various compounding pharmacies but discovered that the standardization and regulation were lacking. Her friend and tennis partner recommended that she see me. When I first saw Miranda, I assured her that one size does not fit all. And since she had had a hysterectomy earlier for heavy bleeding and fibroids, we discussed that she didn't need to take progesterone and that she only needed to take estrogen, which would definitely help relieve her hot flashes, improve her sleep, improve the collagen in her skin, improve her hair texture, as well as restore the integrity of her vaginal mucosa. She still had her ovaries in place, and she wasn't complaining of any sexual dysfunction or decreased sensation. And she was able to climax, although she noted sexual activity was a bit less comfortable since entering into menopause. Since she was very sensitive to medicines, we decided to use the lowest dose. I showed her a number of different gels. She traveled frequently and did not want to take a large dispenser, such as what Olestrin and estrogel come in. But she liked these little small foil packages of an estrogen gel called Divigel that comes in 3 different strengths that are wrapped in a little tiny individual foil container. I started her on the very lowest strength, 0.025, and she did respond to this within 8 to 12 weeks. And she no longer had significant hot flashes, but not surprisingly, she still had some vaginal dryness because the amount of estrogen you need to stop the hot flashes and help some of the symptoms generally are just not enough for the vulvovaginal area, which has the most concentration of estrogen receptors. At her follow-up visit, we discussed increasing the dose of Divigel to the 0.05 and or adding a local estrogen cream or a tablet or even an insert in the form of Invexi. She decided to elect just a vaginal estrogen alone, and she preferred the tablet Vagifem, and her insurance covered the generic form called Uvifem. And she was afraid she'd be allergic to some of the vehicles in the 2 estrogen creams that are on the market, so she liked the idea of an inert tablet. So how do we customize hormone therapy? It comes in many different forms: pill, cream, gel, tablet, vaginal ring, and spray. Now, pellets are available, but they're not FDA approved, and I do not recommend them because they cause very high doses, which causes tachyphylaxis, meaning the body kind of gets used to it, kind of like not exactly an addiction, but somewhat of a tolerance, and then the levels drop. One thing that's great about being a midlife woman today is that there's more ways to customize therapy than ever before. And your physician, if experienced, can help advise you on which delivery method's right for you and your lifestyle. But don't let swindlers hoodwink you or take advantage by asking you to pay exorbitant fees for extensive testing or tempting you to buy directly from them. Don't believe that their products are simply completely safe and totally risk-free, because nothing is risk-free. What kinds of hormones are in hormone therapy? Well, the therapy is very personal. We know that estrogen is very good for the vagina, the skin, the hair, the bones, and the hot flashes. But for some women, depending on symptoms and medical history, estrogen may not be enough and other agents are needed. So we can prescribe estrogen alone if there's no uterus or endometrium, or estrogen plus a progestogen, which can either be natural progesterone or a progestin, either in combination daily, continuously, or cyclical, especially in recently menopausal women or perimenopausal women. Estrogen and testosterone in combination or compounded testosterone. Unfortunately, the testosterone patch is available in Europe, but not in the United States. Hormone therapy will depend on the individual woman. So a woman who has a total, complete hysterectomy with removal of the uterus, ovaries, and the tubes may benefit from just estrogen alone. But women who have a uterus need the progesterone protection to reduce the risk of endometrial hyperplasia and uterine cancer. On the other hand, if a woman whose main concern is just vaginal atrophy, so-called genitourinary syndrome of menopause, she might opt to use local estrogen or vaginal DHEA and avoid something systemic. On the other hand, there's some women who don't want to put anything in their vagina and they only want treatment for the vaginal dryness. And ospemifene is a non-estrogen SERM that can be taken orally. It was initially studied for osteoporosis, but it interestingly interacts with the hormone receptors in the vagina. It does have a slight increased risk for blood clot if the person is at bed rest, so we don't use oral therapy if there's any concerns about deep venous thrombosis. So, what does bioidentical hormone therapy versus biosimilar hormone therapy mean? Well, bioidentical hormone therapy has caught the attention of women across the world. It simply means using hormones that are exactly identical to human production of ovarian hormones. Biosimilar hormones are hormones found in hormonal contraception and many standardized, well-studied hormone therapy prescriptions. Estrogen. This is the hormone therapy prescribed most frequently. The brand name Premarin, which is composed of conjugated estrogens, has been available for decades, longer than any other, and subsequently has the most research and has been studied the most extensively compared to other estrogens. If a woman is younger than the usual age of menopause and truly needs not just hormone therapy, but hormone replacement therapy, her doctor may prescribe ERT, estrogen replacement therapy. And if she just needs some supplementation to treat problems in natural menopause, her doctor may advise her to use low-dose estrogen therapy. As I mentioned, there's various preparations of estrogen: conjugated estrogens, esterified estrogens, synthetic conjugated estrogens, and estradiol, which is the most potent human estrogen called E2. There's also ethinyl estradiol, which is virtually used in all hormonal contraceptives that contain an estrogen component along with a progestogen. So your healthcare clinician may recommend a form of treatment that's best for your situation. Also, if you have definite ideas about what treatments you prefer, you can ask for different options. You can open the conversation so that you can ask other questions and address all your concerns. Think about how you'd like to have the hormone delivered. Some women prefer the ease of a pill, and others like creams or patches which bypass the stomach and liver and are said to mimic the way the ovary releases estrogen directly into the bloodstream, as opposed to the first pass metabolism of the hormone going through the mouth, the stomach, and then the liver. Women who are concerned, though, about hair and skin generally do better taking oral formulations, while women with high triglycerides will not, since oral estrogens might further increase the triglyceride level. Women with very minor postmenopausal cholesterol problems, such as the falling level of the good HDL cholesterol and rising level of the bad LDL cholesterol, might actually reach better cholesterol ratios with the oral formulation than transdermal. As you can see, every regimen has pros and cons, and every program must be tailored to the needs of the individual woman. It's important to remember that if you take oral estrogen, it can reduce your testosterone level by going through your liver, making more sex-binding globulin hormone, which then binds to free testosterone. So this is a great thing if you're growing a mustache or losing hair on your head like your brother. But it's a bad thing if your sex drive is perhaps already pretty low and you don't have much endogenous testosterone. In general, all brands of estrogen and hormone therapies have similar risk and benefits. And anybody who tells you that their product is completely devoid of potential risk or side effects is simply lying. Now, one of the biggest issues I deal with is it's great to want to customize and individualize based on the individual woman and go along with her preferences. But unfortunately, a lot of prescription insurance plan formularies are restrictive. And that doesn't mean that you still can't choose the hormone therapy you want to, but you may have to pay cash. You may have to go about it in a somewhat different way to make it potentially affordable. And we're going to have an upcoming podcast on my first series of podcasts going over content on our website on speakingofwomenshealth.com. My second series is continuing medical education credit for doctors and nurses and pharmacists, although any woman is certainly free to listen into these very interesting conversations. And this third podcast is me podcasting and updating my book, The Cleveland Clinic Guide to Menopause. So more on customizing hormone therapy. Estrogen plus progestogens are available both orally and also by patch. You can do this continuously combined, where both are given every day, or cyclical. And when it's given cyclical, the estrogen is given all the time, and the progesterone or progestogen is cycled for 12 days a month. If you've got a uterus and you only take estrogen alone, you have a 2 to 8-fold time greater risk of uterine cancer if you only take estrogen long-term and you don't balance it with a progestogen. And remember that progestogen is the term that encompasses both progestins, synthetic versions of the hormone progesterone, and natural progesterone itself. Because of the risk of uterine cancer, combined estrogen and progesterone therapy is necessary for anyone with an uterus. Progestogens protect the uterus, decrease the estrogen-related chance of overgrowth of the lining of the uterus, which over time can lead to uterine cancer. Studies show that combining estrogen with progesterone negates that increased risk, but there's still a baseline risk, and it might lower it below the baseline risk, but it doesn't make it zero. So even if you're on progesterone, if you have abnormal bleeding and you're over 40, it has to be evaluated. So if you take combination therapy, you'll either take a continuous combined regimen or a cyclic regimen. And this can be done orally or via patch. When progesterone and estrogen are taken daily, this is the continuous combined. And the goal of this regimen is preventing any vaginal bleeding, especially after being on it for 6 months. But if you take so-called cyclical or sequential hormone therapy with estrogen every day and progesterone just days 1 through 12 of every calendar month, then there can be bleeding on or after the month, after the 10th of the month. No bleeding is fine, but if there is bleeding, it should be when expected. And the 10th of the month avoids almost all of our holidays except for Mother's Day. I think that cyclical therapy is good in women who have breakthrough bleeding that doesn't go away with changing the estrogen progesterone dose, and also for younger women who need higher doses of estrogen, women that it's not clear if they're perimenopausal or fully menopausal, because then if we know that the bleeding's on schedule, we're not worried that it's abnormal. So what about testosterone? With estrogen or compounded? Interestingly, we women have more testosterone gram for gram than we have estrogen. So calling it a, quote, male sex hormone is a bit of a misnomer. But men do have 10 times more testosterone than we women do. But we're certainly not lacking in it. That is, not until the ovaries are removed, or in a small percent of women until after menopause has begun. For many menopausal women, having extra testosterone may mean having some extra side effects like acne and irritability and oily skin. But some women with very low testosterone levels do see improvement in sex drive, energy, muscle mass, and bone health with testosterone. About 1 in 6 women may need testosterone after undergoing a hysterectomy. And please see the podcast chapter 9 that we did. Currently, the only way to take testosterone for menopause is in a formulation that combines it with estrogen. And initially, there were 2 brand name products, Estrotest HS and Syntest HS. And that combined oral esterified estrogen with methyl testosterone, which is a synthetic testosterone form of oral testosterone. Then it became available as a generic called Covarix, but now that one's not available, and it's only just esterified estrogen and methyl testosterone. There's no current FDA-approved way to give testosterone transdermally to women. There was that female testosterone patch called Intrinsa, and it looked very promising, and it was approved in Europe, but it was nixed. The company decided not to pursue it. And I think some of that had to do with the confusion over the supposed increased cardiovascular risk that the Women's Health Initiative study showed. And we've gone over that study on my 5th podcast in the first series, going over the 20th anniversary of the infamous WHI. So I personally think the testosterone approach should have already been approved in the United States. But like I said, it came up after the FDA approval, right after the controversy of the WHI, as well as the issues about the safety of the arthritis drug Vioxx, which was pulled from the market. So I think that the FDA advisory committee was being overly conservative and paternalistic towards women, and the all-male panel was not particularly impressed by the fact that Intrinsa's formulation helped improve women's sexual activity by only 1 extra episode of sexual activity per month. Even though for most women, it's the quality of sexual contact, not the quantity of sexual encounters, that's important. And women in the study importantly reported that their sexual satisfaction significantly improved compared to baseline. In fact, many participants wanted to stay on the patch after the study ended. So I do think with the help of a knowledgeable physician, of course, they should have the option of deciding what's best for them. Interestingly, Intrinsa has also been studied in postmenopausal women not on estrogen and has shown improvement in sexual function. But because the patch is not available, we're left with generally compounding. And it's very easy to overdose. So if you're going to use testosterone, you really need to see a menopausal hormone expert. And so many of these fly-by-night, cash-paid, so-called anti-aging clinics don't give enough estrogen and give way too much testosterone. I can't tell you the number of women I have seen who come in with male levels of testosterone. And many times they say, oh, I feel great. I can take on the world. And I'm not having a deepening voice or abnormal hair loss. And I'm like, well, that's because it can take over 4 years of high-dose testosterone to masculinize a woman. And once it's present, there's no turning back. So the current topical testosterone formulations that are available in the pharmacies are formulated for men, not women. So if women are going to use them, they can only use 1/10 of the dosage. That's why many menopause experts end up working with a compounding pharmacist when women require testosterone. Even though most of us would like to be able to just prescribe a standardized agent that we know what blood levels it gives, like the testosterone patch. But our current situation still involves too much guesswork and, ironically, I think puts women at somewhat greater risk than if the FDA had just approved that testosterone patch for women. What are the types of delivery systems? There's numerous FDA-approved options and several main formulations. Most hormone therapies are available in pill form. They can come in ultra-low dose, medium standard, intermediate, higher, and highest dose formulations. Generally, women who've undergone complete hysterectomy or have experienced chemotherapy-induced menopause or who are very young or have very fast metabolisms may need much higher doses to control hot flashes and other menopausal concerns and maintain bone density. For most women, the physician usually starts on an average dose or sometimes a low dose if the person is sensitive or has been in menopause for several years. And you should be monitored at least within 12 weeks, certainly before increasing the dose. Other physicians may start with a higher dose or a standard dose in women having severe symptoms to control the symptoms faster, and then consider reducing the dose. The estrogen-only pills include conjugated estrogen, which goes by the brand name Premarin, and it's got 10 different estrogens, a complex blend, and it's available in a dose as low as 0.3, which is a standard dose for maybe a woman over 65 or 70. It's also in a low dose 0.45. The standard dose, the maroonish brown tablet, is 0.625. Younger women, though, may need doses of 0.9 to even 1.25, or the maximum dose is 2.5, which is 4 times the standard dose.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
And Juvia was previously available, which was a synthetic conjugated estrogen, but it's not bioequivalent, and I don't believe it's on the market anymore. We had generic estradiol for the longest time, and it's available in several doses, 0.5 milligrams twice a day, 1 milligram twice a day, or even 2 milligrams twice a day. And it's short-acting, so it must be dosed twice a day. Menest is a sterified estrogen, available in doses 0.3, 0.625, 1.25, and 2.5. And we have synthetic ethinylestradiol, which is in virtually all hormonal contraceptive pills, patches, and the 2 vaginal rings. We don't usually use it in menopause unless it's in a very low dose, like 5 micrograms of Femhart, which has norethindrone acetate, or even the low dose Femhart, which is only 2.5 micrograms of ethinylestradiol. And most ethinylestradiol and most birth control pills are 20 or 30 or 35 micrograms. Occasionally, you can find some doses as low as 10 micrograms, and some women with ovarian cysts or women on anticonvulsants who metabolize estrogen faster may need a 50 microgram dose of a hormonal contraceptive pill. So even low-dose pills, as you can see, are still about 4 times higher than the lowest dose hormonal contraceptive. What about estrogen-progestin combinations? Who want to just take 1 pill a day or 1 patch without cycling? So one of the first ones was Prempro, which was what was studied in the Women's Health Initiative, which is medroxyprogesterone acetate with the conjugated estrogen. And there's been some 2 lower dose versions of Prempro, 0.45 with 1.5 or as low as 0.3 with 1.5. Activella is the brand name of bioidentical estradiol with 0.5 milligrams of norethindrone acetate. And it's available in generic forms such as Mimvi and Annabelle's. Activella low-dose version, or Mimvi low, is half the amount of estradiol, 0.5 is the standard dose, and it's only 1/5 of the progesterone at 0.1. So many times that can be helpful in women who are very progestin sensitive. Femhart is the only one with ethinylestradiol and comes in a 5 microgram with a full milligram of norethindrone acetate. And when you give more norethindrone acetate, sometimes that can help with the hot flashes and bone health a little bit to try to compensate for the lower dose of estrogen. And the Femhart low-dose version I rarely use, only in exquisitely sensitive women, like women with maybe some residual endometriosis post-hysterectomy. And that's at the 2.5 microgram, 1 milligram dose. Angelique is bioidentical estradiol, and in America, 0.5 milligrams of drospirenone. But it is available in Europe and Canada with 1 milligram of estradiol and 1 milligram of drospirenone, or even 1 milligram of estradiol and 2 milligrams of drospirenone, which is a little bit less than the 3 milligrams of drospirenone in standard hormonal contraceptives like Yaz and Biaz and Yasmin. So that may help fluid retention and blood pressure. Now, we've had Climera Pro, which is a combination bioidentical estrogen patch with levonorgestrel as the progesterone in a once-a-week patch, which has a little less than the standard estrogen at 0.045, which most standard patches are 0.05 or 50. And it has 0.015 of levonorgestrel. Now, the Combi patch is combination estradiol 0.05 and has 2 doses, either 0.14 of norethindrone acetate or almost twice that at the 0.25 milligram dose. And that must be changed twice a week, which is 3.5 days, which is 84 hours. So as an example, that would be putting on a patch at Monday morning at 7 a.m. and changing it the following Thursday at 7 p.m. Now, estrogen testosterone can be used in women who have hysterectomies or in women who have their uterus as long as they take a progestogen. Prometrium is the only available on the market natural micronized progesterone, and it's mixed with peanut oil, so you can't be allergic to peanuts. And it comes in a typical cyclical dose of 200 milligrams days 1 through 12, or it can be given 100 milligrams at night, nightly, with the goal of no bleeding in 6 months, or sometimes even a higher dose at 200 milligrams nightly. There is a progesterone gel called Prochieve or Crenone, 4%, and it can be used vaginally every other night, days 1 through 11, which really lasts through 12 because it lasts for 48 hours, for women who cannot tolerate any systemic progesterone but still need the uterine protection. Now, that's not FDA approved, it's off-label, so your physician may need to do an ultrasound or an endometrial sampling yearly. Now, in terms of giving the progestogens, Provera MPA can be taken orally, daily, or cyclical. It was the progestin used in the WHI study. It's very anti-estrogenic, so it's good on the uterus, but I don't favor it long-term for use over 5 to 10 years. Micronor norethindrone acetate is commonly used in many birth control pills, of which we have over 50 years of experience with. And it's very well absorbed from the stomach, lasts just under 24 hours, and may have some additional bone benefits. It's also not sedating. So for women who don't like the feeling they have when they take natural progesterone, if they feel dizzy or lightheaded or drunk, it's a very small percent of women. Most women just feel relaxed and actually like the natural progesterone, but everyone is different and has different metabolisms. Now, you've probably heard of the Mirena intrauterine system for contraception or for abnormal bleeding, and that's levonorgestrel. And it's not officially approved for menopause, but if you get one placed in perimenopause, we do know for contraception it can last up to 6 to 7 years, and certainly at least 5 years for endometrial protection if you're using estrogen. You can cycle natural progesterone or synthetic progestins to estrogen. There is a combination tablet called Premphase, which is daily 0.625 milligrams of conjugated estrogen, cycled with 5 milligrams of MPA for 2 weeks. So that's bleeding every 28 days. So that's 13 menstrual bleeds a year. Now, if you use any type of oral or transdermal estrogen patch or gel, and the gels are Divigel, Evamist, which is a spray, and Alestrin. We used to have Estrozor, but that's not on the market anymore. Those can be used with generally 12 days of a progesterone, usually natural progesterone, 200 milligrams at night with a little bit of food in the stomach, because the stomach tends to destroy the natural progesterone. And so women who have a uterus who want bioidentical hormones can use plain estradiol and natural progesterone. And if they want the combination, we do have Bijuva, which hit the market in April of 2019. And that's a 1 milligram of estradiol with 100 milligrams of natural progesterone mixed in coconut oil or medium chain triglyceride oil.
We'll be back after a quick break.
Have you ever experienced fitness failure? You know, you set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
Now, transdermal estrogen, as I mentioned, we used to have a soybean oil-based Estrozorb, but that company is no longer in the market. Divigel comes in 3 different strengths, as I mentioned earlier with Miranda, and the small foil package allows individual, convenient daily dosing. And then Estrogel's been available for some time as 1 squirt a day, and Alestrin is 1 to 2 squirts per day, so you can go up to 2 squirts, a higher dose. And Evamist comes in a little container that's sprayed onto the arm, 1 to up to 3 sprays per day. And you first need to prime the dispenser before starting. And there's 60 sprays, which generally would last most women 2 months. Some women only 20 days if they're using up to 3 squirts, or 1 month if they're using 2 sprays. And interestingly, the levels of estrogen, while low, appear to peak around 3 a.m., which could help with sleep and night sweat reduction. Generally speaking, vaginal creams are just used to treat vaginal atrophy, dryness, itching, burning around the vagina and vulva. There's estrase vaginal cream, there's generic estradiol cream, and then there's the Premarin vaginal cream, conjugated equine estrogens. In terms of the vaginal rings, you have the Estring, which is a very low-dose vaginal ring, and a small circular piece of silastic plastic containing a tiny bit of natural estradiol. It's inserted easier than a diaphragm, and it releases a steady dose of estrogen for 3 months. And it's nice because it treats vaginal dryness, and it is used in women who otherwise cannot take or tolerate estrogen, such as women with blood clots or a history of breast cancer. But if the woman has ascus atypical squamous cells of unknown significance, which can be from vaginal atrophy if there's no HPV infection, or if they're women with vulvar symptoms, the ring won't help that, and you'll usually need cream or vaginal DHEA. At some point, hopefully, we will have a DHEA vaginal ring. In fact, I thought about studying that, and when I looked online several years ago for a patent, I found out it was already in phase 3 studies in Europe. Now, FemRing is a local and systemic vaginal ring. So it treats the vagina, but it treats the whole body. And it's available in 2 strengths, 0.05 and 0.10. And it's changed every 3 months. And it's usually useful in women who've had a hysterectomy, who want local and systemic benefits of estrogen, who don't want to take a pill, don't want to apply anything to the skin, and don't want to be reminded about things. The only downside is sometimes it doesn't last a whole 90 or 91 or 92 days. And it may only last 87 days. And women who are very sensitive to drops in estrogen, like migraineurs, I've had a few women not tolerate it, and insurance won't generally cover for you to get it sooner than every 3 calendar months. Sometimes I've substituted really high-dose vaginal creams for that last week if women think that it's conking out, just to try to push a little estrogen systemically. So what's the difference between bioidentical hormones and conjugated estrogens? Well, bioidentical hormones are identical in molecular structure to the estrogens and hormones created in the woman's body. And they're not found in this form of nature naturally, but they're synthesized from plants. Conjugated estrogens are a mixture of several different estrogens that are either derived from equine urine or synthesized in a lab. Now, we do have vaginal estradiol tablets that can be inserted with an applicator and aren't as messy as creams. And they do reduce the risk of recurrent bladder infections like a string. So Vagifem was the brand name. It's usually inserted nightly for 2 weeks to the lower third of the vagina, and then twice a week, like Monday, Thursday thereafter as maintenance. There's also the Invexi vaginal inserts, which are 10 micrograms of estrogen, like the Vagifem, Uvifem. But there's also a uber low dose 4 micrograms available, also inserted any time of day, doesn't have to be the night. And I think there's better adherence and better effects, because sometimes when I examine a woman and get a pelvic exam and PAP, I can see a tablet on the wall and I'll say, oh, did you just put your Vagifem or Uvifem tablet? And I've had so many women say, oh no, that was 3 days ago. So I like the Invexi insert better, and it's mixed with a little coconut oil. Now, there's lots of different estrogen patches, and they range in size from smaller than a dime to the size of $50. They're usually applied to the bikini lower area of the abdomen or lower back or buttocks, and they're generally completely waterproof and stay on when you shower or swim. Most last a week, but others last for 3.5 days and need to be changed twice a week. So Climera Pro is the one that has weekly estrogen with progesterone, levonorgestrel. But the plain Climera is just plain estrogen, and that's available in doses as low as 0.025, which is 25 to 37.5 to the standard 50 or 60, 75, and the max is 100. Now, the Vivel Dot or Minivel Dot is smaller in size and changed every 84 hours twice a week. And it comes in standard doses of 37.5, 50, 75, or 100. Now, if you cut the 100 in half, you get 50. If you cut the 75 in half, you get the 37.5. There is a 25 dose of Vivel Dot, but it's generally only marketed for bone health and not necessarily hot flashes. But regardless of dose, all women who are taking any estrogen who has a uterus still needs to take progestogens either daily or cyclically. Now, Menistar is the lowest dose of the estrogen patch, and it's half the size of a 25, which is 14 or 0.014 milligrams. And this dose is so low that it's not approved for the treatment of hot flashes, but it has been studied in women ages 60 to 80 who don't have hot flashes but have bone thinning or osteopenia and want to use a weekly patch for osteoporosis prevention. And the dose is low enough that a woman with a uterus need only take a progestogen for 12 days once a year or at most twice a year. But if you use anything higher than this 0.014 microgram dose, you need to use progesterone nightly or at least for 12 days cyclical a month. So you might ask, which delivery system's best? Well, I like to show women in my practice all the different types of hormones so they can choose the one that's most convenient and that best fits with their lifestyle. I find women who live in very humid environments or who perspire a lot don't like patches. Women who travel a lot seem to like the little foil applicator containers like Divigel. But women who want really fast drying quick method and they don't want to wash the estrogen gel off their hands might like the Eva Mist spray. Other women prefer oral estrogens and only want to take it once a day, like Premarin. A word about generics. Well, generics may be less expensive, which is nice, but generic estradiol that's not mixed with progesterone or progestogen has to be dosed twice a day. Generics only have to be 80% equivalent to 125% equivalent to brand names, and that's a pretty wide range for a potent substance like a hormone that has a relatively narrow therapeutic window. Also, the strengths between generic batches can vary, so every month can feel like a hormonal roller coaster with varying levels. The same is true for generic thyroid hormone and generic bone medicines. I generally prefer brand names because that's what I personally would want to take for myself or my family. But unfortunately, these pharmacy benefit managers and insurance plans many times make that exorbitant unless you do cash pay or coupons or other tips we'll talk about in future podcasts. So what are some questions to ask your physician? Why should I take hormone therapy? Which hormone delivery method is best for me? Do I need both estrogen and progesterone? Should I take the lowest dose of a standard therapy or a standard dose or a higher dose? And how long should I take it? And what are the side effects I should watch out for? And what are the risks? In general, I can tell you that for most women, the benefits far outweigh the risk. And the main risk is actually the risk of blood clots, not cancer. But you can have increased risk of uterine cancer, which can persist for several years if you've taken compounded unregulated hormones. And one of the most common things I see women do is prescribe transdermal progesterone. You can swim in that, and it's not going to protect your endometrium. It has to be taken orally by synthetic progestogen patch or applied intrauterine or vaginally. You can rub estrogen on your skin and absorb it. You can rub testosterone on your skin and absorb a lot of it, but not natural progesterone. And for women who say, oh, I am taking wild yam extract. Well, yams can convert that into progesterone, but we humans are not yams and we cannot. So there's a lot of confusion out there by people who I think want to help women but are not schooled in the endocrinology and pathophysiology and pharmacodynamics and genetics of menopause. Birth control for perimenopausal women. Well, hormonal contraception by pill, patch, or vaginal ring is an effective way to reduce menopausal symptoms in women who have not completely stopped having ovarian function. At this time, a woman may still need pregnancy protection. And even if she's not bleeding because maybe she had an endometrial ablation, if she's still hormonally cycling, she's still pre or perimenopausal. So hormonal contraception is a logical option for healthy women who absolutely do not smoke at all and have normal blood pressure and don't have blood clots or any significant medical problems. So in addition to providing contraception, the hormonal contraceptive pill or patch or vaginal ring can help also curb hot flashes and night sweats and irritability, control bleeding, and also help skin and hair and mood. Hormonal contraception has been shown to reduce bone loss that can occur in perimenopause, and it's also associated, if there's estrogen along with the progestogen, in reducing the risk of ovarian cancer, and they do not increase the risk of breast cancer. Women who take the pill or forms of hormonal contraception tend to have lighter and less painful periods, less fibroids, and if they take the hormonal contraceptive continuously, they don't even have to bleed. Women who are non-smokers and in general in good health can take hormonal contraception until they're 55, 56 years of age. If they don't need contraception, maybe they're not sexually active, or they've had a tubal ligation, or their only sex partners had a vasectomy, or they're a lesbian, then usually we stop hormonal contraception by 51 or 52, the median age of menopause. But not at a time that is a hectic time in a woman's life, like her child's going off to college, her daughter's getting married, she's going through a major job change, or caring for elderly parents and has several work deadlines. You really want to pick a time to make that transition that's good for you in case you do have remaining ovarian function, which can lead to abnormal bleeding and extra office visits. But any form of hormones orally, in terms of the pill, hormonal contraception, or hormonal therapy, and transdermal or even vaginal hormonal contraception also can increase the risk of blood clots, whereas menopausal transdermal hormone therapy does not. And again, clot is generally the most serious risk. And as I've mentioned, low-dose hormonal contraception can still deliver 4 to 5 times as much estrogen as in menopausal hormone therapy. So when a woman's on the pill, she gets enough estrogen to prevent those ovaries from releasing an egg and hormones. But some women experience menopausal symptoms during the week they take the inactive dummy pills. But when they resume the active pills, the symptoms disappear. And really, no woman should go more than 4 days without hormones because the ovaries can start to produce an egg on day 5. So the old-fashioned way of taking a birth control pill for 21 days on and 7 days of dummies is medically does not make sense. So if you're in this situation, you have a choice. You don't have to have a period, and you don't have to take the inactive pills or mark that time on the calendar. So in fact, the initial design of the active pill taking for 21 days followed by 7 days of inactive pills is essentially obsolete because 7 days is simply too long. You can start getting ovulation, you can start getting headaches, cramps, migraines, mood changes, hot flashes. So some of the newer options are the 24 4-day regimen where you have 24 days of active hormones and just 4 dummies. So low estrogen 24-FE iron has 20 micrograms of ethinyl estradiol and a milligram of norethindrone acetate. Yaz and B-Yaz are 20 micrograms of ethinyl estradiol with 3 milligrams of drospirenone. And in B-Yaz, all the pills, including the 4 dummy pills, contain levomefolate, which is a long-acting folic acid. And this is the first hormonal option that's FDA approved to treat severe PMS or PMDD. It's also indicated to treat acne and has a very favorable progestogen that's actually based on a spironolactone analog called drospirenone. And it seems particularly beneficial for skin and hair concerns. It's also not associated with bloating, which can occur with some progestogens. And if a woman has done very well on Yaz or B-Yaz or Yasmin or Safril, I favor using Angelique for hormone therapy, particularly if she's had acne. Similarly, if she's done very well on low estrogen, I would consider transitioning her to Femhart or potentially Activella or Mimvi. Seasonal was the first long cycle pill to have 12 weeks of active pill with 1 week of inactive pills, leading to just a period once a season. But you don't even have to have a period once a season, and I still think even every 3 months going 7 days without a hormone is too much. There have been approvals of a continuous 365-day pill. It was initially marketed under Librel, which I don't think is on the market, but really any hormonal contraceptive can be used in a continuous fashion. For women that have menstrual migraines or hormonal sensitivities or hot flashes or sleep disturbance, I think going with a continuous regimen is very beneficial. There are triphasic pills, which I generally don't recommend. Having a different hormone level every week can be irritating to the brain. And if you're trying to become pregnant, that's one thing. You need to naturally cycle and have fluctuating hormones. But if you're not trying to become pregnant, incessant ovulation is not needed or desired in many cases. Now, there is one hormonal contraceptive called Nastasia, which has bioidentical estrogen in it, and it has differing doses of progesterone or progestogen every several days, and only 2 dummy pills. And it's specifically formulated and approved for abnormal menstrual bleeding. And it's one of the few hormonal contraceptive pills that you can take and still see an increase in the FSH. If you're on synthetic estrogens like phenylestradiol, the FSH is going to be suppressed. Now, if you're on a progestin-only pill like Micronor or Arin, or the newer Slind 4 milligrams, which is drospirenone, then you can still every several months or a year check the FSH and estradiol to find out when you've crossed over perimenopause to menopause. If you're on the synthetic pill, you cannot check the hormones. There'll be no measurable estradiol because you're on a synthetic estrogen and your ovaries are suppressed and the FSH will be suppressed. There's also another birth control pill that uses a natural E4 called Nextstellis, and that is another option. And we have a full 1-year vaginal ring called Annovera, which has a progestogen in it, which is very anti-androgenic and anti-mineral corticoid. So it's not associated with the typical fluid retention and bloating that some progestogens are. And it's labeled to put in the vagina for 3 weeks and take it out for a week to have the artificial bleed, but then put the same ring back in. But functionally, most of us just say put the ring in and use it continuously for the whole year. And if there's any breakthrough bleeding, take it out for 4 days, rinse it off, and then restart again. NuvaRing is a hormonal vaginal ring that lasts only for 3 weeks, and then you're supposed to go a week without. But again, whether it's a pill or a vaginal ring or a patch, if you go 7 days without any hormone, you can theoretically ovulate, hence the stories of women who, quote, got pregnant on the pill. There's a estrogen progestogen synthetic patch for contraception. Initially marketed as Ortho Evra, is now available in a generic patch, and it's associated with a slightly higher risk of blood clot because the patch with menopausal hormones reduces it because it avoids the liver. But when you use synthetic doses of estrogen in a pharmacologic dose, not a physiologic dose, to suppress ovaries, the area under the curve in terms of the amount of hormone exposed is actually higher with a patch than with a pill. And sometimes the patch in women that have a very high body mass index may not suppress ovulation. So again, one size does not fit all. We have excellent free treatment guidebooks on hormonal contraception, contraception options, including non-hormonal options, and menopause and hormone therapy on our speakingofwomenshealth.com site. So if you're on hormonal contraception, how can you tell when you start menopause? Well, you can certainly stop the contraception for several months and see if you get a period and check your hormones. But if you're only off it for a few days or a week, it's not enough time. And if you're sexually active and you can get pregnant, you should definitely use a form of backup contraception. And since you have to be off hormonal contraception for several months before you can correctly interpret the lab test, if there's not a pressing reason to go off, you don't have to go off just because you've hit a certain birthday. So hormone therapy and quality of life. Many women who take hormone therapy say they just feel better taking it than they do when they're without it. They have fewer problems with skin, with hair, with vaginal atrophy, with their mood, with sexuality, with brain function and brain fog and hot flashes. So you can't measure these considerations as easily as you just measure blood pressure or height or body weight or cholesterol levels. Nonetheless, they hold particular importance for many women. And because there's no one therapy that addresses all these concerns, many women do find that hormone therapy remains their best bet. I see some women who avoid hormone therapy but then end up on sleeping medicines, mood medicines, cholesterol medicines, osteoporosis medicines, and use expensive over-the-counter vaginal moisturizers and lubricants. So many times, standard, relatively inexpensive hormone therapy can cover all of those domains for many women. Now, if you've been taking hormones for over 5 years, some physicians might say, oh, maybe you should try to go off or taper the dose. However, if you're under age 60 or even 65 and have had bad hot flashes, going off the hormone therapy, even with tapering, leads to at least a 50% resumption in hot flashes, and based on data out of Finland, can actually be associated with a higher risk of stroke and heart attack. So there's no artificial time limit, and if you're taking it for bone health, you only have the benefits while you're taking it. If you're taking it for vaginal health, the same thing goes. But if you've been on hormones for over a decade and you're on a synthetic progestogen, which may be linked to a slightly higher risk of being diagnosed with breast cancer, although this is certainly not clear, or if you're approaching age 65 and are concerned about an increased risk of stroke on oral estrogen or oral estrogen progestogen, or if you think you're not getting any benefit from it or you've already taken it for a decade, or if you're having issues like breast tenderness or bleeding or bloating, that's when changing the formulation to a patch or reducing the dose in half or going off the therapy and reassessing can be considered. But if you just abruptly stop hormone therapy, even if you taper it too, you can get your insomnia and hot night sweats and hot flashes back. Bone loss will occur again in 50% of women. Mood changes if you're not sleeping well. And over time, vaginal thinning, bladder thinning, genitourinary syndrome of atrophy affects a vast majority of women. So the hormone therapy timeframes. Some women don't ever take hormone therapy, but some women need hormone therapy for just a limited time, 5-10 years. But there are many women who want to take hormone therapy indefinitely or need to. Women who have stopped hormone therapy or have never used it certainly may need either local vaginal estrogen therapy or vaginal DHEA. And half of women who are not on hormone therapy can be losing bone, and that needs to be assessed. It's important to realize there's no time limit to feeling good, but it does need to be reevaluated periodically, such as in yearly, just like with any therapy a woman may be prescribed. For women who start hormone around the time of menopause and continue it for 5 or more years, they actually have less heart disease, less coronary calcification, less diabetes, and a lower death rate. So I am not in any hurry to tell a woman arbitrarily she needs to stop hormones. I ask her to listen to her body, periodically get reevaluated. Certainly as a woman ages, metabolism changes, so a lower dose of hormones may be as effective as higher doses when she was younger. Now, slowly tapering off hormone therapy does not make it less likely that you will suffer from symptoms. So I take the lead from the woman how she would like to proceed. But if you're no longer on hormone therapy, or you never took hormone therapy, you still must pay attention to the status of your bones and genitourinary system, i.e. the vagina, because these areas are particularly sensitive to the loss of estrogen. Again, remember, there's no time limit. The goal is to have neither too few or too many hormones, but just the right amount. And determining your optimum hormone balance means listening to your body and seeing an experienced clinician if problems arise. For example, trying to determine the right hormone balance for a woman is much more complicated than determining whether her thyroid replacement dose is too high or too low, or even in a diabetic, whether the insulin dose is too high or too low. While many women require lifelong thyroid hormones, about 1 in 8 women, others never need a thyroid hormone for their whole life. Just like there's some women who don't need hormones, or maybe only need it for a short period of time. That said, at least half of all women lose bone after menopause, and without estrogen, most women will experience thinning and atrophy of their reproductive and urinary systems. And they'll also lose collagen in the skin and hair. Another example is millions of women have benefited from taking the hormonal contraceptive pill, a synthetic combination of estrogen and progestogen. In human history, no other agent has been studied as much as the so-called pill has. It certainly allowed women reliable control over reproduction for the first time in human history. And it's certainly a pharmaceutical that has revolutionized women's lives. Nonetheless, many women have never used the pill or any form of hormonal contraception, and they don't ever want to. They prefer to avoid any synthetic hormones. But hormone therapy of any sort. Others who never needed the pill or who perhaps were unable to take it still may be interested in menopausal hormone therapy. So again, one size does not fit all. Younger women have many choices when it comes to controlling their body's menstrual cycles and reproductive capacity. And you know what? Midlife women should have as many ways to maximize their health and vitality. And hormone therapy should be one of those options. So thanks for joining me back in the Sunflower House. I'm Dr. Holly Thacker, your host and author. Please be sure to join me for Chapter 12, Boosting Bone Health. And please subscribe anywhere you get your podcast and give us a 5-star rating. And if you like our work and want to give us a donation, please go on speakingofwomenshealth.com and donate. Be strong, be healthy, and be in charge.